I am taking the liberty, actually, of changing the title that Gordon gave me to... Why this is not... Oops. To a somewhat broader title, and you will see in the course of my talk why I did that. Where we're coming from is really the tail end of applied science, namely the quest of changing the performance of what we're all trying to get to, namely personalized healthcare, precision medicine. And that actually reminds me to issue a disclaimer. As opposed to all of you, I'm actually not a card-carrying glycobiologist or glycoscientist. I spent the better part of my career in the development of personalized healthcare, precision medicine, and that is what attracted me actually to join the field and to join Interven, a company that is very deeply vested in glycoproteomics, as you all know. So somehow this is not advancing. Let me just, is this better? So the bane of personalized healthcare obviously is the availability of biomarkers that informs us about the very specific attributes of any one patient and how they may or may not respond to a therapy. And what we have here is a bunch of biomarkers from the nucleic acid realm, as well as from the protein-based realm. And what you see here is that by and large, the performance of these biomarkers is really nothing to write home about, with relatively low either sensitivities or specificities. And so the idea that we had in terms of looking at glycoproteomics was that we could dramatically expand the depth and the breadth of the repertoire of potential biomarkers using glycoscience, using glycans, which clearly add many, many orders of magnitude to the complexity of potential biomarkers, particularly if you combine proteins, proteomics, and glycomics. And in first approximation, that massively larger repertoire of analytes should translate into a much more informative repertoire of analytes, particularly also because, as opposed to genetics, genomics, which is sort of, if you will, fairly upstream and remote in the biological, in the cascade of biological biomarkers from genetics to proteomics and post-translational proteomics, with glycoproteomics, post-translational proteomics, you really are much, much closer, much, much more proximal to where biology happens in a dynamic fashion on a day-to-day basis, if you will. And so by combining proteomics and glycomics, we believe we're opening the door to this powerhouse of glycoproteomics. Obviously, you're all familiar with the fact that up to 70% of all secreted proteins are glycosylated. And this, and again, I'm preaching to the choir here, of course, glycosylation of a protein clearly affects its structure, its conformation, and therefore also its function. And of course, no talk about glycoproteomics can be completed these days without mentioning the world's most famous glycoprotein, namely the S antigen of the of the COVID virus. And in as much as obviously we all deplore what happened over the last couple of years, one of the upsides of actually the COVID pandemic might be that there's been a little bit more attention paid and publicity to the fact that proteins are glycosylated. And so we still obviously are all engaged in the task of explaining and proselytizing to the world how important glycosylation is, and that, I guess, is one of the small upsides. So the best example that I always use to illustrate how powerful glycoproteomics could be in the realm of personalized healthcare is actually a molecule or a test that most of us are familiar with, namely prostate-specific antigen. And we all know that it's actually not a terribly good test. And that may very well have to do with the fact that when we talk about PSA, we ignore the fact that it is actually a number of different molecules, as many of you may be familiar with, some of which are quite typical, namely the tetra and the triantennary one for prostate cancer, versus the biantennary form that's typical for the healthy state or benign prostatic hypertrophy. And if you're using the conventional immunotools, such as an ELISA, to test or to measure PSA, you're basically just throwing all these apples and oranges into one bucket and looking at the peptide backbone without distinguishing these more subtle subentities, and that results then in a very poorly performing test. Whereas if we're using the submolecular resolution of mass spectrometry and specifically hone in on the molecules associated with cancer, then what we get is a much, much better receiver operating characteristic and a test that really very reliably differentiates the wheat from the chaff. So why isn't everybody in the clinic using glycoproteomics? Well, because it is a tall order. We need these expensive, complicated, to some extent rather temperamental instruments, expert operators. They're expensive, and yet they've actually improved dramatically over the last 10, 15 years, so that at this point we can easily run 100 patient samples within a day or two, and that provides us with precisely the resolution of information of what is the glycan, where is it, what site is it associated with in the protein, and what protein is it, which of course immediately closes down the next bottleneck, namely these are very large data files, and as of course you're all familiar with, the readout of these chromatograms are not nice sinusoidal curves that are easy to interpret, but very, very ragged and complicated peaks. And so the standard of care, if you will, up until now, even with the best conventional softwares, was that processing a data file of 100 patients with 1,000 individual features would really take a PhD 8 months full-time at 45 seconds per feature. So this is where our company actually started, which was founded by a serial entrepreneur who is a software engineering entrepreneur who's worked in blockchain and video image processing, and who was interested, because of a strong family history of cancer, for which he could not really get any answers using genetics or genomics, to apply a different set of biomarkers. And so what they did was set up, using artificial intelligence and neural networking, a process that over a multi-stage recurrent neural network system provides an output that very specifically predicts the likelihood of where the human observer, who is still the gold standard for interpreting these chromatograms, would actually call the beginning and the end of a peak, such that these are the manual labels, and the likelihood curves that the program predicts coincide very, very nicely with what a human observer would call this. This was validated across many, many different molecules with a extremely high correlation between the machine and a expert human annotator. And we've been using this now to apply glycoproteomics to clinical studies. So the way the way this works is that we now, at a extremely high speed, are able to convert the chromatograms into data files that are easily interpreted by biostatisticians, and that has allowed us to cut down the time that it took 8 months for a PhD scientist to literally 5 minutes on the server. And that really, for the first time, has allowed us to scale up glycoproteomics, and specifically glycoproteomics in liquid biopsies, so in peripheral blood, to where it could meaningfully apply to the large clinical sample numbers that you need to have to test this for applicability in clinical scenarios. The way we run this is with a very simple standardized workflow that avoids a lot of the more esoteric approaches, such as depletion of abundant proteins such as concentration or enrichment. We just go ahead, use a very small amount of serum or plasma. We take it through a tryptic digest, and then we apply it directly to the LC-MS platform in an exploratory workflow where we use very high-end instruments, obviously low throughput. So we develop a set of classifiers, a set of spectra using a small number of the phenotype contrasting samples in each indication, healthy controls, cancer patients, or whatever you have. We then process this data through our software. We continuously add to our growing database library of glycopeptides, and then we take a first stab with biostatistics, filter out the few hundred or maybe 1,000, in each case, most informative glycopeptide differences between the cases and the controls. These are converted into MRM panels. Now we can apply that very specific, glycopeptide analytes on a triple Q instrument to a much, much larger number of samples at very high throughput, very high quantitative fidelity, and we end up generally then processing it once again through our software with a half a dozen to 2 dozen of glycopeptide differences that carry the bulk of the information. Those are then modeled by machine learning into multivariable algorithms that we refer to as our glycoproteomic classifiers, and they can then be tested again on additional patient cohorts. So what we're looking at with this workflow is somewhat counterintuitive and paradoxical with regard to what the rest of the world is doing. All of them, all of the cell-free DNA, the ctDNA approaches that Guardant and Grail are using for early detection of cancer depend on material that's being shed by the tumor. This is why they have trouble actually recognizing early stage tumors, as well as why they need fairly large quantities of serum or plasma. What we're looking at are a set of relatively few, some 70 or 80, quite abundant circulating plasma proteins, somewhere down to about 200 nanomolar. So these are by and large acute phase reactants, immunoglobulins, complement factors, proteins generally primarily synthesized in the liver or in plasma cells, B cells. And what we're looking at here is actually a systemic response of the body towards the presence or absence or certain attributes of the disease rather than the disease specifically itself. And we're still not quite clear how this actually hangs together. This is why, as of lately, we have actually, in addition to the effort of just looking at patient samples, have set up a laboratory of functional glycobiology. And Tomislav Kaval, who is here in the audience, is one of the scientists who works there, to actually drill down and get a better explanation as to how these two observations are linked together. It's important to stress that what we look at is primarily the different representation or relative abundances of individual glycoprotein isoforms. So we do not really depend on measuring the level of the protein accurately, although we strive to do that. This is just an iconic example of if you have a particular glycoprotein where in the healthy control, version A or isoform A is at 20% and isoform B is at 80%, even though in the diseased situation, you may have exactly the same level of 100 micrograms per milliliter. Now we have a shift where glycoprotein isoform A is more highly represented than isoform B. This is perfectly enough for us, and this is what we usually actually encounter. Not so much changes in the level of the protein from patients to controls, but changes in the relative presence of individual glycoisoforms. So it's really a very, very powerful approach. We've applied this to a number of different conditions over the last couple of years. Started out in oncology. Our first big study, and I'm going to talk a little bit about that, was in ovarian cancer. We've since applied it to lung cancer, to pancreatic cancer, to kidney cancer, to nasopharyngeal cancer, to hepatocellular cancer. And the amazing and really striking and almost too good to believe observation we made that in each and every one, literally, of these applications, we find these very impressive performances, very nice areas under the receiver operating characteristic of quite commonly 90% or more in indications where no such tests exist so far. And then in this particular indication, and this is why I changed the title, of hepatocellular carcinoma, we also, by chance, had some samples with non-alcoholic steatohepatitis. And while clearly the signal in liver cancer is quite massive, we also found a very nice predictor in NASH. And that opened our eyes that what we're looking at here is really something that is ubiquitously important and informative, way beyond just oncology. And we have, as you will see, applied this to a number of different disease categories since then and been very successful. So the ovarian cancer story was really the first big experiment that we did, trying to replace what is the current clinical state of the art, a cancer biomarker that distinguishes benign pelvic masses or tumors from malignant ovarian carcinoma. And patients that come to observation with a newly diagnosed pelvic mass, about 20% of them will actually have ovarian carcinoma. But at this point, 90% of them undergo surgery because there's just not a very good marker to distinguish. When we applied our platform to this question, we right away found a very powerful classifier that we were then, this is in retrospective samples, we were then able to validate that in a set of prospective samples, and that gave us the confidence to actually embark in a prospective clinical observational trial, multi-site trial, and international trial. Half of the patients were recruited in the US, the other half in Southeast Asia. And what we found, much to our delight, was that the classifier that was developed on these retrospective samples very nicely validated in the real-world population, while CA125 gave the expected somewhat lackluster performance. The reason I'm highlighting this is because of a second very, very important milestone that we crossed with this study, and that was, can we actually reduce a rather complicated assay to practice? Can we make it or transform it into a clinically and analytically validated, regulatory compliant assay that can actually be used by doctors in practice? And that is not a slam dunk, and it's not anything, as you all know, for the faint of heart, because it's never been done before. And I was very nervous, but now very, very happy to report that we were able to do this. And so this ovarian cancer test is now a fully regulatory CLIA CAP compliant laboratory developed test that is available to physicians. Let me touch on the other point that I just made, namely that this applies not just to cancer, but much more broadly. We were very intrigued by the initial observations in NASH, which was based on a very small number of samples. We then went on and studied a much larger number of samples, and once again were able to replicate or confirm the performance of this test at, once again, a almost too good to be true performance level. And in this particular case, not only could we very clearly distinguish patients with NASH from healthy controls, but we could also, with the same panel, differentiate between early NASH and late-stage NASH. So there's no other test on the market at this point that can do that. Let me move on to some other applications, and we've already been talking about COVID. So this is a study that we were able to do with Stanford University, where we got access to a number of individuals that had a very severely symptomatic course of COVID. Were all admitted to the hospital or to the ICU, and a set of individuals who had a completely asymptomatic course of COVID. Those are people that arrived at the Red Cross blood donation station to donate blood and were found to be seropositive, never knew that they had COVID. And so what you can see is a very, very stark contrast here. We had an interesting additional set of controls, namely individuals with bacterial sepsis. And while you see that there's obviously somewhat more similar to the severe COVID cases, there's clear differences there, such that this is not just an inflammatory reaction that we're seeing here, but something very specific to COVID. And then likewise, another indication in the space of infectious disease, HIV, where we recently had the opportunity to study a number of individuals that had fully treated HIV, so undetectable viral load. These are individuals that, for all intents and purposes, look exactly like a healthy individual, except for being seropositive. They have normal CD4, normal CD3, normal CD8 counts. And yet, when you look at them at the level of their plasma glycoproteome, they're like day and night. So very, very stark. We're continuing to look into this to gain more insights into what exactly we're looking at here. These are very early preliminary results. And then the last set of indications that I'm going to talk about that we applied this platform to is, again, one in oncology, but this time it is predicting therapy response, specifically to immune checkpoint inhibitors. These, as many of you may be familiar with, are really have brought about a sea change in the treatment of cancer, extremely powerful drugs, with the downside that they only work in a subset of cancer patients. So 1 in 3, 1 in 4, dependent on the indication. And at this point, there's really no good biomarkers to predict who will or who will not be a responder. The one that's most commonly used is PD-1 or PD-L1. And as you can see, in malignant melanoma, it's basically useless. And and oncologists actually are not even using it anymore for malignant melanoma. When we applied our platform to this, again, in a relatively small pilot study of about 40 patients, immediately we found a classifier that gave us a hazard ratio of 9, very clearly distinguishing individuals that did very well on the therapy versus those that really fared very, very poorly. And again, here we have been able more recently to complement this with a much larger study with about 200 or more than 200 individuals. And again, the initial observations held very nicely. And what you see here is that individuals that test positive for our test, and we call that the DAWN-IO immuno-oncology melanoma test, in other words, are predicted to respond to the therapy. They have a median progression-free survival time of 17.5 months versus those that test negative, i.e. are predicted to not benefit from the therapy, have a median progression-free survival survival time of 2.5 months only. So this is the second test that we have now put on the market. It's available to oncologists, and it's being launched as we speak. It was announced at this year's American Society of Clinical Oncology meeting. So at this point, we really believe that with glycoproteomics and glycoscience, we may just have a new crystal ball for the practice and the progress of precision medicine, personalized healthcare. And let me close with a quote by a famous physicist, and I hope to have at least contributed to what he was saying, namely, before you came here, you were confused about the subject. After my lecture, you may still be confused, but hopefully at a somewhat higher level. Enrico Fermi. Thank you all so very much for your attention, and I'll be happy to answer some questions.